Psychiatry. My name is Dr. Wawa. I'm a consultant psychiatrist currently working at Kenyatta National Hospital. And the reason we are having this webinar is to encourage psychiatrists, especially the younger psychiatrists and other healthcare workers and in the county hospitals, just to feel more comfortable about seeing and treating children with childhood and developmental disorders. I know for most of us, I can speak on behalf of them because I'm one of them. We only have a 3-month rotation when we're doing our second year postgraduate, and after that, when you go to the counties and you're left to see children, you feel a bit helpless and lost. And there's this temptation that you have to refer every child that you encounter to Dr. Normundi that occurs. And I know that overwhelms her because now she has a lot of children to see, and some of them we could have seen ourselves. So we're just trying to encourage us to see children, to familiarize us ourselves with the services that the children usually need and can get, and also just use this forum to establish linkages and referrals to not just KNH, to other places that we might need to refer the children and any other services that the children need. So we can have a conversations as this is ongoing in the chat box. Any questions you have in the question and answer box, and our panelists will answer them. This is a CPD-accredited webinar, so KPA will send tokens via email to all the doctors who are attending. So we have 4 speakers. Everybody is bringing in their unique knowledge and their expertise on what we are talking about today, child psychiatry. The first speaker is Josephine Normundi. She's a child psychiatrist at KNH and a mentor to many of us. Karibu Daktari. Then we have Mr. Mickey Baron, who is an occupational therapist at Kenyatta National Hospital. Ms. Salome Gataka Araka, a speech and language therapist at Kenyatta National Hospital. And Dr. Muya, who is an early career psychiatrist. She's my former classmate in postgraduate and my former colleague as well at Machakos County. She's working from the Machakos Level 5 Hospital, and she's always been very passionate about working with children. So welcome, everyone. So thank you. Okay. We'll start with Dr. Normundi. So she'll take us through a few of the things, and then we'll bring in the other panelists. So Dr. Normundi. Yes. Thank you. I'd like you to just tell us what are the common child disorders that you encounter in your practice, the children, and what are the treatment modalities for these conditions that are available?
Okay. Yeah, thank you very much, my colleagues in this field and the listeners. Child adolescent psychiatry is a subspecialty in psychiatry, and it entails working with the children and the youths up to about 26 years. These are children who have disturbance of behavior. Of course, in psychiatry, many times we talk about disturbance of behavior, but for the children and some of the adolescents, it's disturbance of behavior, which is related to their development and also the circumstance that they find themselves in. So we see them because somebody has observed something wrong and therefore they seek for help. There are common child psychiatric problems which are also encountered by the developmental pediatricians. And these problems such as attention deficit hyperactivity disorder, autism spectrum disorder, mental retardation, learning disabilities, and then a few of the psychotic disorders. Now, when you move to the youth, we realize that this is the time we start seeing disturbance of behavior in relationship to their conduct at school and at home, and then the use of substances which manifest in different behavioral disturbances. Now, the modalities of management, of course, there are many other disorders like elimination disorders, eating disorders, and enuresis, yeah, and many others. But the treatment modalities range from, let's say, the treatment involves a multimodal approach, whereby the focus is usually to bring the child to the right developmental trajectory as much as possible. So the correction, if picked early, then we have to engage other specialists in management of these children, like speech therapists, the occupational therapists, sometimes physiotherapists, special education teachers, and not forgetting the most important part of the child's life, that is the caregiver and the parents. Thank you.
Okay. Thank you, Dr. So then I'll go to the next question that I'd like to ask. If I'm sitting in I've just been posted maybe to a hospital in one of the counties, and I go there and find that there's only an adult clinic, but there are some children who are trickling in and adolescents here and there. Is there any advantage of having a clinic for the children and adolescents separate from the adult clinic? Is it something that's recommended, or should you just see all of them together at the same time? Dr. Normundi?
Hello. Oh, sorry. You can hear me?
Yes.
Okay. Now, obviously, somebody who is trained in psychiatry should be able, let me put it this way, somebody who is trained in pediatrics and also somebody who is trained in psychiatry should be able to pick some of this behavioral disturbance or evaluate the child, and probably may not be able to intervene, but can do an appropriate referral, because all our other colleagues who are involved in management of these children should be found within the hospital setup. Now, you'll find that, of course, the training in psychiatry is more of adult focused and a little bit of child psychiatry. So many of our colleagues tend to just, dismiss any of the children who have difficulties, and but if they take enough time and they have some more interest, they're likely to pick the problem and be able to advise or intervene as expected. So you really don't have to have a child psychiatrist in that in the hospital. One a psychiatrist and also a pediatrician should be able to make an appropriate diagnosis and try to intervene as best as they can. And if not possible, that's when they can do the referrals. Thank you.
Okay, thank you, Dr. So if, again, I'm sitting there in the county and I decide I would like to set up a separate clinic.
Yes.
What do I require in terms of personnel and maybe equipment? Are there any special things I would need to just do a basic setup?
Yeah, that's a common question that I get all the time. But what I can say is you don't need specific equipments. All you need is the passion for the job, and then go to the basics. And the basics means having a table and a chair and the child and the parents where they can sit, and probably having some toys which can help the child do exploration as you observe the behavior, a pen and a pencil. Those are the very basic that you need. And I think any of us can be able to afford that in their areas of work and come up with a diagnosis. So there are no complex equipments that are necessary for making a diagnosis or for seeing these children, because all you need is yourself and then observation of the child. Now, if there are any other interventions like laboratory tests, because for some you need laboratory testing, you may also need radiological testing, then you can send to the laboratory. But that is now somebody else's docket, which of course exists in all our hospitals. Thank you.
Okay, so apart from the psychiatrist,
yes,
and the table and the chair,
yes.
Are there other people we might need maybe to consult to bring into the picture? A psychologist?
Oh yes, yes. Oh, yeah. In terms of personnel, there are times that you need a clinical psychologist who will do some further evaluations. Like you may have a child who you are not very clear at what the problem they are having with regards to learning. And so you send for further interventions and to the clinical psychologist who is likely to now do a comprehensive psychometric testing so that we can have clarity on probably the IQ of the child, maybe the personality traits, and also other things like their concentration and their abilities. So we may not see that in general observation, but if you want specifics, then you send to the clinical psychologist. Now, there are those other ones who have motor problems, like some children are not able to chew, others may have speech problems, so then you have to engage the speech therapists. You also have to engage the occupational therapists. And in fact, one thing that I had forgotten to say earlier is that some of the children with intellectual disability, or what we used to call mental retardation, may have multiple other limitations. It can be vision, it can also be hearing. Then we may have to now send them to for assessment in hearing. You can also send them for assessment for their vision, so that we have clarity that there's no sensory impairment, which can of course impact on their learning, or they are not, in what they see words upside down, and that again interferes with their learning. So you have to engage all these other professionals who will help to look at this child in a holistic manner and be able to come with a good diagnosis and a proper intervention. Thank you.
Thank you, Dr. So apart from this internal linkages as we talked about, and the internal people we need to just comprehensively manage the children, you had already alluded to the fact that we might need to bring in the education part of it, so that so I just wanted briefly, I know it's a big thing, but briefly, yes, just talk to us about the education, the special education system. Where do we send? Who do we send to? And for school placement, I'm seeing somebody has actually asked a question. Kindly ask Dr. Normundi how we can go about assessing children for school placement. I know that's a big thing. So could you take us through that?
Or how to assess a child, or who are these?
When we have assessed a child and we think that this child has a learning disability, so what next? Yes,
if you can remember in your own primary school and high school and now university, there was almost like a one pattern of teaching, because there's that assumption that the child will be able to learn. And so we use conventional methods of teaching, where the teacher writes on the blackboard and asks questions, or projects something that is prepared in the computer, and then they teach and ask questions. Now that is the conventional way that we have been taught. But there are children who cannot learn like that. There are those who have learning disabilities, and we need to use other non-conventional ways. And so we refer them to the educational bodies And the main one that we have in our country is Kenya Institute of Special Education. They are the headquarters. They have very good facilities, and they also do their own educational assessment. They also have good knowledge of these developmental issues, and they will know where to place this child, whether in a regular school or in a special school, or in a combined type where you have a special class in a normal school, or the child is placed in a regular class, but will be given some individualized attention so that the child can learn. Sometimes we also recommend that the child is subjected to what we call audiovisual learning, because the child is not able to write, but the child is very good in verbal knowledge is very good, but the child cannot write. So when we recommend audiovisual, it means the child can see and will know and will be able to read when they see. But when it comes to writing, then it's a problem. So they need to be assisted that way. If there are no audiovisuals, then we ask for a facilitator who can help the child, like those who are not able to read, but they can understand. So somebody reads for them, and then they are able to understand and comprehend and give correct answers, and then maybe recorded or somebody writes them down. So there are those kinds of interventions. Then the other intervention is having them sent for what we call registration with the National Council for Persons with Disability. Now, these developmental issues, some are categorized in the group of disabilities. So these children, if they are not recognized by their parents, then somebody else needs to recognize so that they are also categorized properly for the future. Because let me give an example of a child who has, let's say, severe mental retardation. Now, this child may have a lot of limitations with regards to judgment and also predicting danger. Such children are at risk of being abused by maybe neighbors or even family members. Now, when the child is already registered and it is known and an abuse occurs, it may even be sexual abuse. If that occurs, then having been registered, this child is likely to get other services which will help the person to be taken to court, and so that the child can be protected in another way. Now, parents may not be available. Like just recently, we had a child who had whose mother died, and this child was autistic. So the family members had to come in. But unfortunately, the child was just registered, but nobody knew anything about the child. So we had to take this child through a whole evaluation so that they can have some documentation, and then hopefully the family members will be able to understand and take the child into custody, into their custody or care, or it can be foster care. So it is good that the children are recognized, acknowledged, and also recognized by the state through registration. Thank you.
Thank you, Dr. Somebody has just asked as a follow-up, I think let's just answer this one right now, about the letters to KISE.
Yes.
How do you go about writing?
How I go about writing?
I think they probably have gotten letters from KISE to them and they don't know what to do, and then they'll end up sending to you. So maybe just tell them what.
Excuse me.
Sorry.
Yeah, now I think we have standard way of writing letters, but all these letters that we write to KISE or we write to other institutions or to schools, they are medical legal documents. And if they are medical legal documents, there's certain information that we may not put in, but there's some information that are critical. The demographic information is critical. the person who takes care of the child is critical, then we need to know who referred that child. Was the child referred by the teacher, or was the child referred by a relative, or even the Sunday school teacher? You know, the referring agent is important because we'll know then who is concerned about that child. Because some parents may not even know, or in the process of their arguments, especially the fathers, they think that the child has no problem, the mother is just making a fuss. Then we need to know what has brought the child to the hospital. That must be documented. Like I always ask, if it's a 10-year-old child and has a developmental problem, which should have been picked at 1 or 2 years. So I ask, why now? Why wasn't the child seen those days, and why now? So many times you're told, oh, it is because of school, or it is because of examination, that the child is going to sit grade 4 examination or grade 6 examination, or is already registering for KCPE. So they need to know whether there are special conditions that should be assigned to this child so that the child can then be able to compete fairly. Now, as you continue writing, you need to add on the details about a pregnancy, about the delivery, about after delivery, the sensory and motor developmental milestones, the schooling up to where the child is at the moment. Why is it important? That information is important because it gives information on the perinatal factors that could have contributed to the child's status at the moment. It informs the teacher. It also informs the educators who are trying to place this child in school. It also helps us to know that should there be a subsequent child or a subsequent pregnancy, then there are things that must be looked for. After that, the family circumstance. Does the child live with the parent, or does the child live with a caregiver, or are the parents alive or they are not there? And why are they not there? Like grandparents take care of these children. Aunties and uncles take care of these children. Are there risks of this child being abused where they are? Then we need to know which school the child is attending, still as a part of family circumstance. And then observation. What have you as the clinician observed? And observation does not require anything complex. It is exactly what you see, from the motor activity to the child being able to face you and greet you, to any other odd movements that you see, the expression of speech, what is the quantity and the quality of the speech, the child's ability to engage in terms of taking instructions, the child's ability to hold a pen and be able to write his name or her name, and even the names of other family members, the child's ability to ask questions and comprehend the questions that you give to the child. Then you also need to document the reading ability. Can the child read simple letters, simple 3-letter words and complex words? Can the child comprehend those words? And you also test numeracy or mathematics ability. Does the child know numbers? Can the child add them? Also comprehend what subtraction, multiplication, depending on what grade the child is. That is really a general overview of the child. And also, if there are any, what we call dysmorphism. Dysmorphism means any abnormalities that you see on the face of the child, the ears, the head, like those who have microcephaly, you need to document that. And then the child's ability to cooperate, and eventually put all that together and make a diagnosis. So it is as simple as that. So if we have any questions, then you can now send the child forward to a clinical psychologist to do the other details so that we can have a specific diagnosis. Thank you.
Okay, thank you for that. We've talked about the clinical psychologist and doing psychometric testing.
Yes.
Could you tell us where if we don't have the clinical psychologists in our facilities and we'd like to utilize this service, where can we send
Yeah.
children, and at what cost would it be?
Yeah, in our country we have not, let's say, the mass, the population, in the general population, we have not reached a level where we have a good access to the clinical psychologists who are trained in psychometrics. We can actually count them, but I know in Kenyatta we have from the university. We also have one from the Department of Mental Health. But in Aga Khan, I don't know if they have one, but I know they have psychologists. In other private sectors, we do have those who are practicing privately, clinical psychologists who are able to do psychometrics, but the cost is enormous, because you are talking of cost of from 50,000 and above for just doing the psychometrics, and then have recommendations. So we try to limit that, because in the public sector, the type of patients that we see are those ones from the average and the lower cadre of economic affordability. So they may not be able to afford that kind of money. And that's why it's important that we do our best in terms of observation and get as details as possible. In fact, many a times we don't even send to the clinical psychologist. Many a times we are able to make a diagnosis, and it is good enough for the subsequent intervention for the child. Thank you.
Okay, thank you, Dr. Sari. So we've gotten to a point where we are now feeling confident we can set up and see children, and we know who we need to link with internally and externally. So what challenges would you say that you have had and for us to expect when working with children, and how should we deal with these challenges?
Yeah, there are challenges from the family perspective, and also challenges from the resources that we have, and then challenges from school. Now, the family challenges, I think I had mentioned one, whereby once a child is recognized to have a problem, the parent, the father of the child may not be able to take in that reality that the child has a problem. So many times the fathers abandon these children with the mother. So that is a challenge, and we find it very difficult to engage them. So these mothers go through a turbulent period, and sometimes they go through mourning with the knowledge that the child has a problem which has no cure. So we help them to mourn through and then accept the child and be able to make the right decision, of course, with the information given, so that the child can go through the right trajectory. The other challenges that we see is more so in schools. As much as we expect the teachers to have been trained in educational psychology, they are not all of them are equipped to know what the child's problem is. So you'll find a child who has very low self-esteem because the child has encountered ridicule and a lot of corporal punishment because the child is not able to give an answer or is not able to write or read as to expectation. So then the child is rejected. And so when you see the child and send them back to the school, the child will not be accepted. So they have to look for another school. So so the first time when I see the children, I advise the parents that when you take the child to school, be prepared that there's a possibility of the child being rejected. So if the child is rejected and you cannot, you're not able to negotiate, then you look for another school and another one. At some point, you will get a teacher or a school that accepts this child. KISE has tried to involve the schools as much as possible, but we are still far off. Maybe we have only captured about 30% of our schools with the knowledge and understanding of these problems. The other challenges are other children who then bully the child because of the deficits that they're having. And then in some aspects, there are those parents who would wish to adapt the children. So when they go to the children's homes and they take a child who is about maybe at the age of 3 months, by that time, maybe you have no idea how the child is going to be. So when they stay with the child for about 6 months or 9 months, then they start seeing some characteristics forming. By the time you evaluate the child, you realize that the child is autistic. Now they don't know whether to take the child for adoption or they don't know whether to return the child. So that is one of the challenges that I've come across. The other challenges are related to acceptability of the child within the family, because then if the child is rejected by the own father, then visiting relatives may be a problem. And culture and religion has a big role to play, because before they even come to hospital, and that's why I ask, where were they when this child is 10 years and has a problem? Many a times they go for spiritual intervention. So it has been prayers and prayers and prayers and exorcising, and also demon removal, and then herbal treatment or witch visits to the witch doctor, to the neighboring countries or even neighboring counties. So there's a lot of time wastage that takes place, so that we are not able to do early intervention. And early intervention means before the child is 4 to 5 years. That is the best time that you can intervene and help the child to get as much as possible. So our African society is really contributing to these late interventions. And that's why this forum is very useful, so that we, as healthcare providers, we should be able to pick these children as early as possible, instead of pretending that all is well. Now, our colleagues in the other fields of medicine, they are also a challenge, because clinicians or doctors are not able to say that I don't know. They don't admit that they don't know. So they sit on the child, or they continue advising the mothers or the fathers that, your child is just naughty, or your child, don't worry, the child is going to develop. Again, that wastes time, and then early intervention does not take place. So I think those are some of the challenges. I'm not sure if I'm able to exhaust them, but I've tried. Thank you.
Yes, you've actually told us quite a lot, and those are things that we can build up on. So I'd just like you to briefly touch on the types of schools that we have for children who have development. Just briefly, I mean, I think that's one of the things that people write in the letters to KISE, because one of the recommendations would be what school to place this child in. And if we don't know the types of schools, it might be a bit hard for us. So just take us briefly.
Okay.
Yeah.
Okay, thank you. Now, it is not the clinicians to place the children, but it is good to just have an idea of what type of school to send the child. Now, the under 8s or the under 9s, if you find a 6, 7, a 4-year-old, those ones with developmental issues, unless they are extremely severe, they should be in a regular school. Why? Because that environment has structure, and there's a lot of stimulation in a regular school. So we give the child that opportunity to learn with the other children who are okay. Those ones whom we find and they are above 9, 10, those ones we recommend. For some, we recommend that they continue with regular schooling, but with individualized program. Like the 9-year-old who, let's say, is not able to read very well, but can read and is slow. Now that child, if you send to a special class, the child may possibly deteriorate. So when you look at the circumstance, then you make a decision. You can recommend that the child remains in a regular class for stimulation in other areas of development. What are these other areas of development? Socially, physically, and emotionally. So it is now the other aspect of the cognition, cognitive development that will be taken care of by the individualized program. Now, there are those we find who are above 12 or 13, just around adolescents and pre-adolescents. Those ones will not stay in a regular class because there is already an attitude of the child and attitude of other people. So they end up being ridiculed and their self-esteem goes lower and lower and lower. So those ones are likely to fit in an integrated school, or what we call a special class in a regular school. When they are placed in a special class in a regular school, they are trained according to their pace. When the child is able to understand and the teachers feel that now it is time to transfer that child into a regular class, so the child is moved to a regular class. So there's always the shifting to the regular, then to the special, to the regular, until the child is able to finish the formative years. Then there are those who, especially adolescent and the old, 15-year-olds, or sorry, not 15, those who have reached late adolescence and youth. That period, then we advise that they are put in a special school, but boarding, so that they can learn more about independence in self-care, socialization, and then structure, and probably be trained on other skills that does not necessarily involve intellect, like handwork, making certain artistic work, which can then eventually be sold. So those are the categories, and there are those special schools, like special schools that just admit those who are blind or those who are deaf. We also have a special school for autism, but for now we are trying to discourage completely special, especially if the children are very young. Thank you.
All right, thank you. That's a lot of information that I'm sure everybody will find useful. Now, the last question. I know you've talked a lot.
It's okay.
So maybe we have a patient a child would like to refer, okay, yes, to Kenyatta. Some of the things that I know I get called a lot by my colleagues. They're like, yes, what is the cost? What is the referral procedure? What should we do? So maybe we can just let everybody know right now, so that they know that if I need to refer a child, what should I do and how much would it cost? You know, all those other things.
Okay.
Yeah.
Now, in KNH, we have two categories of patients. There are those who pay by cash, then there are those who pay by NHIF, and then there are those who have other insurances. I'm not sure if we take other insurances unless at the private wing. But for the public side, the cost of consultation or for seeing the child for the first time is about 1,250, I think. And then the subsequent seeing them is about 800. Now, if they need documentation, these medical legal letters and reports, there's an additional of 600 shillings. So if a mother, we advise the parents to come with about 1,800 or 2,000, which will help them to get everything. Then we can do the necessary referral. Privately, it is different. Then when we have to refer them to physiotherapy, again, the payment is different. So then they'll have to prepare for more funds. Generally, it is not expensive. It is affordable for there are those who are not can get a waiver in Kenyatta. As an outpatient, they will not be able to get a waiver. Thank you.
All right, thank you, Dr.
Sarah, back to you.
Yes, thank you, thank you. We had you. Next, I'd like to invite Salome. Salome is a speech therapist currently at Kenyatta. I'd like her to just tell us about what is this speech therapy. You know, we sometimes hear about it a lot. And we're not too sure what it is. So Salome, what is speech therapy, and what do you do when we send a child to you for speech therapy?
Thank you, Dr. Wawa. Yeah, speech therapy is an area of medical care which is specialized for children with communication disorders, language disorders, and speech disorders. Yeah, it is specialized or it is designed for individuals as they come. And when these individuals come, the first thing is you assess the patient for the diagnosis. Then when you do this assessment, you'll be able to know how to start the therapies. If you assess and find the diagnosis and you see the child cannot be able to be attended to because of the behavior like hyperactivity, then this is where you refer this child to the occupational therapist. You can refer also to mental health for further assessment and diagnosis. Also, because a child who is not talking, when they come, you need to rule out hearing loss. So you find you need to refer this child to the audiologist for audiological assessment.
Okay, thank you, Sally. So the next thing I'd like you to tell us is who should we refer then for speech therapy?
Any child who has a delayed speech needs to be referred for speech therapy assessment. Then also patients with communication neurobehavior, like the autistic children, they are also referred for speech therapy. And other cases like speech and language and disorders, and then also cognitive disorders, they can be referred for speech therapy. Also, other areas like adults can be referred, especially if they have lost their speech because of maybe traumatic brain injury, stroke. Children with dysfluency can also, not only children, but also adults can be referred for speech. And also those patients who doesn't have speech because they have undergone surgery like laryngectomy, they are also referred for speech.
Okay, thank you, Salome. We've noticed that speech therapists are I think it's few, and it's very hard to get one because I remember when I was working at Machakos Level 5, we really tried to find somebody even to come for a day, the day we're doing the clinic, and it was almost impossible. So could you tell us, is how the distribution of speech therapists in Kenya, how many are you, if you have, or maybe just an estimate, mko wapi?
Thank you, Dr. Wawa. Speech therapists in Kenya, there are not very many, there are few. I think roughly a number of around 35 speech therapists, and very few are found in government hospitals. Like in Kenyatta, you find there is a speech therapist. You can also find a speech therapist, they are found in Kise and Kenyatta University. You find the speech therapists there. Those are now the government institutions. In some regions, you can find speech therapists who are practicing privately. In Western Kenya, we have the Greenhouse. It's an non-governmental organization which is working locally within the area, but there are also there is a speech therapist in Kisii and Kericho that is now within the country. Then you can find speech therapists at Gertrude's Children's Hospital, which are private hospital, also in Nairobi Hospital and Aga Khan Hospital. And then there are others who are working privately, a few.
Okay, thank you, Salome. It's important for us to know where to send children who we feel like might benefit from your services.
Yes.
I'd also just like you to tell us what, when we are sending, because sometimes the mothers will ask, how much is this going to cost? How many sessions are we going to have? So could you estimate for us maybe how many sessions you normally do, and like how often would a child need to have sessions, and what are the rough costs estimates?
Yeah, when a client is referred for speech therapy and assessment is done immediately the patient comes, or if they are booked patients already, we do unbooking. Now, this patient has been assessed and a diagnosis is made and treatment is planned. Then we do see our clients on weekly basis. We book and see a client every week. Those who are able to pay, they can be seen twice per week, but normally most of them prefer once per week. Then it continues on weekly basis. But the challenge here is that looking at the type of clients who are referred to us, then they are not able to maintain these therapies consecutively as it is supposed to be. Yeah. So there you find, you book a client will come once, twice, 3 times, and then disappear. So you are not able to do a follow-up on those clients. Yeah.
Okay, and so if the clients are not able to have the proper follow-up, what should we expect from their progress?
We are not able to tell how the progress is because we are not able to reach up to them when they don't come. But those who are persistent and they are continued following up the treatment, then you find the progress is good.
Okay. Are you maybe is there an association of speech therapists or something like that? And is there anything that speech therapists in the country are doing just to make this service more accessible? Because we can see it's something that's very important and something that's needed, but the services are very far and wide. So is there anything that can be done, or anything that is being done?
Yeah, there is an association of speech and language therapists Kenya, which is there. And it is collaborating with some of the institutions, training institutions, like recently they collaborated with KMTC, and a course has been started for diploma course, which is a training for 3 years with the ongoing internship. That is one. Then KU is also training students for speech and language therapy at the master's level. And there are other ongoing talks, consultations within Nairobi University to start a bachelor's degree on speech and language and audiology together. And also, yeah, I think those are the areas which have collaborated so far, so that speech therapy services can be improved in the country.
Okay, I'm glad. I'm sure most of us are glad to hear that that there's more people being trained and more facilities are coming up to offer this training. So we're hoping in the next few years we'll have more speech therapists. We used to have a similar problem, sadly, for psychiatrists, where for the longest time we're below 100, and now I think we're getting more and more in numbers as the interest is growing. So you will also get there. Asante sana.
Thank you.
Okay, thank you. I'm seeing from the chat that there is a speech therapist at RFH Specialist Hospital in Ruai and Kiambu Level 5 as well. So anybody who might be closer to them might access the services there. So Mr. Baron, I'll ask you to just take us through a similar, what Sally has done. Just tell us what occupational therapy is and what does it entail.
Well, thank you very much. I don't know if I'm audible enough.
Yes, I can hear you.
Yes, you're okay.
Yes, I'm okay. Please, Dr. Josephine. So, occupational therapy basically is a healthcare profession concerned with how people function in their respective roles and how they perform the activities. Basically, the profession focuses on the promotion and restoration, maintenance of productivity, and also management of people with different abilities and disabilities. Yes, please.
Okay, Baron, so who should we refer then for OT? And we are talking about children, so what children with working stops. There's a lot of echo when I'm speaking. So I don't know if you have two devices on. Anyway, just go on. You can answer the question.
Okay. With occupational therapy, we see diverse clients from children with various disabilities, also adults with various disabilities, be it through a function, through an injury, or whatsoever. Basically, we see children with developmental issues, first of all. If it is physical, that is maybe cerebral palsy, hydrocephalus, and etc., etc. And also, when it comes to mental health, now we see children with different abilities. It is autistic children, children with ADHD, children with learning disabilities. So we focus on restoring their function and addressing their issues, the occupational issues, so that now they can perform adequately in the society or in the community at large. Yes.
Okay. So Baron, I know that most of the hospitals in the country have occupational therapists, but whenever we refer children to them, they say they are not attached to children. And so I was just wondering if there's special occupational therapy.
Sorry, I'm not getting you. Don't know if it's my network.
Yeah, your network is a bit shaky. We can't hear you properly.
Okay.
Okay, maybe Baron, you can try and sort out that issue. Then we speak to Dr. Muya as you're sorting it out. Is that okay?
Okay. Yes.
Okay, Dr. Muya, are you ready?
Yes, Dr. Wawa.
Okay, so we can.
You can hear me?
Yes, we can hear
Okay,
you.
sure.
We can also see you. So, so the reason that we invited Dr. Muya here is because you know that Machakos Level 5 started a child clinic. So we just like her to take us through how they went about their setting up, why it was decided to set up, when this happened, the location they got, the facilities, did they get any special equipment or any personnel? So I'd just like you to take us through that so that you can encourage anyone else who's thinking of doing the same to do it.
Okay, thank you, Doc. So we had our first child psychiatric clinic on the 3rd of March, 2020. So this was an idea which we birthed while I was still in school because I knew I'd come back to Machakos, and Dr. Wawa was already there. So we were discussing on how can we better services at the facility now that will be 2 of us. And we felt that separating the adult clinic and the child clinic would be a good idea. So we started the idea, we floated it to the admin, and they were very receptive to it. In terms of venue, the hospital had a youth center, which whose mandate was to offer services, youth-friendly services to the youth. And it was being manned by a nurse who's done a bit of counseling. So we were, there was a bit of back and forth, but eventually they agreed to host the child clinic. We ran it on Tuesdays. So on the other days, the youth can be seen, the youth needing counseling and all the other services. But on Tuesday, we ran the child clinic. And then how we were able to get the patients. So in the adult clinic, which we ran on Thursday, we were seeing under 18s. And we felt we weren't giving them the attention they need. So months prior to starting the clinic, we talked to the records officer to book anyone who's under 18 to the child clinic, which is done separately from the normal outpatient clinic. So that gave us numbers, though that took time. Even now, we still see 17-year-olds, 16-year-olds coming to the Thursday clinic, but we are very intentional to tell them the next review will be in the child clinic. So that gave us the numbers. Then we also are working with the pediatricians in the hospital. We inform them we are starting a child clinic. So if they have patients who they feel need our attention, they should refer appropriately, which we've been working very well with them. So they have sent numbers. The MCH also does the same. And we have level 4 hospitals, which are run by clinical officer specialized in psychiatry. We inform them we are starting the child clinic. So they started referring upwards to us. In a clinic review, we see a minimum of about 5 to 10 because children take a while to clock. So we also wanted to deal with a number we can manage. So on average in a month, we see about 20 to 30 children in total. Some months are higher, some months are lower, depending. And then the beauty about using the youth center, it's a bit far from the normal outpatient clinic. It's actually on a different side of the hospital. So it's a bit more quiet, it's a bit more exclusive, and it's spacious. So the room has, the place has about 4 rooms, and the waiting bay is inside. So for the mothers who are children who are hyperactive, they can still play and they're still indoor. There's no much traffic of people and of vehicles. So it's a bit more comfortable for the mothers and the children as well. So that venue has worked very well for us. On the bit about personnel, so we had the psychiatrist. The hospital has one clinical psychologist and 2 counseling psychologists. So each Tuesday, there's someone allocated, a psychologist allocated to run the clinic with us. Then we have the nurse who helps us with the registry. She's also the one who keeps the files and the records of the patients booked and keeps in touch with them and reminds them of their clinic review. And she's essentially the contact person on the ground. She's been very, very useful in setting up and running the clinic up to now. Then we work with the occupational therapist in the hospital. They don't come to the clinic, we send the children to them. Like you said, most of them are not comfortable working with children. So some they're able to help, others they refer to Kenyatta. So that's a point of need. Then we also work with the social worker. Our setting is a public hospital. So most of our patients come from very needy backgrounds. The basics of food, shelter, and clothing are difficult. So the social worker has been very instrumental. In the hospital, we are able to waive at least for medicine if they need medicine, and the review, it's made free, especially for those needy ones. And they have also become a contact with the social workers in the community to see if we can get further help for the patient and the guardian. We also work with other departments, like I say, the PEDS team. We don't have a speech therapist, though there's one in town in private sector, though most of our patients are not able to afford to use them. Then we work with the ENT, especially for the autistic children when we want to make sure they're able to hear. So we send to them, they're able to do audiometry and then send back to us. We also get children who are blind, autistic, and all that. So we send to the eye clinic and they're able to make assessment and advices appropriately. So yeah, that's more or less the personnel we've been able to work with so far. Yeah.
Okay, thank you, Dr. That's a great job you guys are doing there. Dr. Mondi amesema congratulations. I think all of us are thinking that it was an excellent decision that you made. So have you found any advantage of seeing the children and adolescents on their own as opposed to how it used to be before? Is there anything that you've seen that is better?
It's definitely worth it because our adult clinic is quite heavy. We see 40, 50 patients. Some come in handcuffs, they're aggressive, they're violent. So in situations where we would have minors there, it would be a bit traumatic for them. So, and then the numbers are high. So there's the bit where you're seeing them fast to clear the queue. So if a child is there, they don't get the attention they need. And we know children, at times they're not able to express themselves. You need time to observe and all that. So separating the children and reducing the number, because we've said the maximum we see is 10. So we have the time for each child and the place is quiet, is comfortable for the children. That has been a plus. You can even see it in the caregivers. They look more they look forward to the clinic reviews because as they wait outside, they talk among each other, they get to bond. So it's kind of homely, if I would say. So yeah, definitely a plus. Yes, definitely a plus.
All right. What challenges have you experienced during this time, and how have you gone about just dealing with the challenges as they come?
Okay. The challenges are many. Dr. Omondi mentioned some of them. What she mentioned is purely what we are also dealing with, especially the bit of patients coming late, late presentation. Just recently, about last month, I saw a girl, a class 8 student who came to us. She had repeated many classes. So she was about 17 and in class 8. And somehow had gone through the system and no one had ever picked that the child had intellectual disability. So there's the habit we have of you ask the child to write something to you. So I noticed the child can't even write their name, and they can't do much in terms of writing, expressing themselves. They're slower than normal. So even when you ask the mother, she somehow says, we never noticed anything different. And the teacher's same story. And you assess on the other social skills and other bits of intellectual disability. They were glaring, and somehow they weren't found. So there is that bit where they come late, and now the child has esteem issues because they have had to repeat classes all through trying to get certain grades. So that is common. And then we also come from a community where there's a lot of stigma in mental health. So first they go to the witch doctor, they go to the religious leaders by the time they get to us, which is a big one. In terms of resources, the personnel, like we said, we don't have a speech therapist. The one available in private sector, most of our patients are unable to afford. And it's been difficult. The psychologists we have aren't trained in the psychometric test. So there are times we have to refer upwards, and yeah, we're not able to do the detailed psychometric testing. Then also the OT team is not comfortable most of the time working with children. So we've had to refer upwards. Then resources, of course, being a public hospital, we have toys. We were able to get some toys from donors. We have kitchen sets and blocks and all that, but they're not adequate. And then, yeah, they keep getting lost. They keep getting destroyed because the kids get excited when they find them. So we keep asking for more. It would be beautiful to make the place more friendly. Yeah, but we are grateful for what we have. Then, like I said, you find, especially the children who are really sick, the guardians are unable to work because they're fully caregivers to these children. So they come with issues of they don't have food, they don't have shelter, probably they've been chased from their homes, and it's such a burden. We have tried to get sponsors for the same, and it's been difficult. Yeah, so that would help. But also registering them to get the disability card so that they're able to get the benefits of people living with disability. That has helped a lot because there are also benefits for guardians, especially for the severely affected children. So that has helped a bit. Yeah, but these are real challenges for our patients and for us. Yes. And of course, medication is not available. Yeah, it at times we get supply, we don't get supply. It's not regular, and the patients can't afford to buy. So that's a big challenge. Yes.
Okay. Janet, when I'm just hearing all the things you guys are doing and all the challenges you're going through, it's like, wow, you're doing a lot. You're doing a lot of great work. So we hope that anybody who's listening and who's been contemplating and be thinking, should I not, can be encouraged by what you're doing. And also, if anybody needs any pointers, I guess you're the go-to person because you've established a very solid unit there. So asante for sharing with us what you've gone through and how you've been able to sort out the challenges. I'll try to get back to Mr. Baron. Mr. Baron, can I hear you? Are you able to talk now?
Yes, please. I think I'm okay now.
Yes, now you're fine. Awesome. So I think I had asked who should be referred for occupational therapy.
Okay. Maybe I can pick it from there.
Yes.
So basically, we have children with different sensory processing disorders, and an occupational therapist, we will evaluate the child for what we call sensory defensiveness and sensory cravings using batteries of tests, as well as we do observations and interviews with the caregivers. So we develop a client-centered practice, tips to raise like children with different sensory processing disorders. And basically, OTs, we can rewire the brain in quotes so that children can appropriately integrate and respond to sensory inputs, allowing them to both make sense of and feel safer in the world. So basically, we also do like attention span and arousal level for children with different attention spans. And an OT can help you discover why your child is highly distractible and help the child to achieve a state of attention and interests needed if he or she is to cooperate in therapy or in school. So also during our interventions, we use a lot of behavioral modification just to achieve our goals with our patients. And currently in Kenyatta National Hospital, we have a sensory integration gym that we were privileged to be to find donors. At least right now we have like inflows of patients, and now we can be able to manage them. So different children with different needs, they require occupational therapy, be it kids with activities of daily living issues, that is maybe toileting, dressing, grooming, or even feeding, and even basically having a bath. And in my years of practice, I have noticed that we have children with toileting issues, and it has been a major concern for us, especially children with autism. And for us, we try to address these issues according to, if you will ask yourself, what does toileting entail? And for us, we will check and assess the child if he's able to use the toilet supplies, if he's able to manage the clothing, maybe if it's unzipping or pulling the trouser down, maintaining the toilet positions, doing the transfers from, sitting position and even standing, and even cleaning the body and caring for continence. So all this, we look it as occupational therapists in terms of managing activities of daily living, which I've already mentioned above. And then also we are involved in learning assessments. Our learning assessment, basically, it's not like the EAC assessment. Basically, we work closely with the teachers to ascertain the type of learning style that the child benefits from, be it if he is auditory learner or a visual learner or an audiovisual learner. So basically, we provide a very comprehensive report for our learners, and also just to facilitate their school placement. Yes, please.
Okay, thank you, Baron. Well, learning a lot. I didn't know that. I think one of these fine days I should take a walk and just see what you do. Sometimes I just refer people to OT and I'm not too sure what's going on there. But it seems like there's a lot that's happening, and maybe we should take a bit more interest and just go there and see. Now, I'd just like you to tell us, Dr. Muya had said that they have occupational therapists at Machakos Level 5, but most of them are not comfortable dealing with children. So is there more training they need for this, or how does one go about that?
Thank you very much. So we have occupational therapists in the county levels, and what we do a lot of training and empowerment. And also maybe the challenge that they might face is perhaps maybe infrastructural aspect of things. But we, in conjunction with the Kenya Occupational Therapists Association, we train our occupational therapists, or rather we equip them with knowledge that enables them to, handle such cases. But in instances where they refer, perhaps maybe, as I mentioned, it's infrastructural structures and also lack of equipment. And that's why, like currently in Kenyatta National Hospital, we have actually one of the best sensory integration therapy treatment room in the country. That's why now you find them referring these patients to us. But I believe that with the guidance of our association, we will be able to work on that. Yes, please.
Okay, Mr. Barron, you've talked about KNH. Are there other places, in case anybody would like to refer, that you know that might have facilities?
Okay, as I had mentioned earlier, we have all occupational therapists in the counties. So I believe if the psychiatrists in the various counties, if they can collaborate with the occupational therapy department, then I believe they would be able to work on something. But we are also planning to go into the counties and empower occupational therapists, and also basically try and reduce this gap that is really, really becoming a havoc to us. Yes, please.
Okay. Thank you, Baron. Thank you for the information that you've given us. Now we'll move to a question and answer session. I think some of the things have already been assessed. Dr. Omondi, there's a question here. How do we go about a case where a child is exhibiting conduct disorder symptoms and also exhibits ADHD symptoms? I understand conduct disorder is a comorbidity of ADHD. Is medication enough, considering that the parenting style is authoritarian? Not so sure.
Wow. Yeah, that's complex, but sometimes ADHD complicates to conduct disorder. Sometimes they are comorbidities. However, by the time the child reaches conduct disorder, it actually tells you that parental control is lost. So if parental control is lost and teacher's control is also lost, then the child is facing the world. Now the world is very hostile. So this child is likely to develop inappropriate defenses for survival. So we have to reevaluate and look at what is the age of this child who has reached conduct disorder, and who is available to help the child. So we engage the services of the children's officers in hospital, in the hospital setting. We call them medical social workers, but in the periphery, there are children's departments who work together with the courts. Now we have to ask the children's officers, who are social workers, to come and evaluate the situation. They listen to the case, they do their own evaluation on the family circumstance, and then they engage the criminal justice system, so that in the correction of the conduct disorder, it is not just because parents have lost it and the teachers have lost it. So, and this child is still young and needs schooling. So there has to be some measures that are enforced. And who does the enforcement? It is the courts, the children's officers, the police, the parents, and the clinician may not be involved unless there's a place where they have to give medication. So that is a complex scenario. On another hand, if that is not possible, then this child may be confined into a reformatory. It can be the Boston, or it can be any other reformatory. But many a times our society doesn't have those kind of services. There are very few, if at all. I know in Nairobi, we have one of the Bostons in Committee, and then we have the approved school. I don't know if they have in other places. There are not very many in this country, but the circumstance that we find ourselves in is that some of the children who have gone to the approved schools, they come out having been criminalized, because it's supposed to be correctional, but they become more criminals. So if the correction doesn't happen, the children fall out into the society and they go to the streets, and then they start becoming criminals. So that is what happens. So if we can prevent before getting into conduct disorder, and that's why we say in child psychiatry, parenting is a key factor. School is a key factor, parenting is a key factor, and then the clinicians and other healthcare workers that we've had today should be involved so that the child does not deteriorate into conduct disorder. Thank you.
Sorry, thank you, Dr. This question, I think, still to you, talking about persons with disability.
Yes.
Is epilepsy a disorder requiring registration?
Now, it depends on where you find it, but the children that we see who have epilepsy, they also have intellectual disability. In that case, they are the right candidates for registration with persons with disability in this country. You may find a child who has epilepsy but doesn't have intellectual disability. But as the disease progresses, the disability sets in. Sometimes you have a disability, then epilepsy sets in. So the two coexist. There are few who escape some form of disability, intellectual or learning disability, but majority of them do have some form of disability, and therefore they need to be registered.
Okay. The next question might, we don't have a psychologist with us, but maybe Dr. Normundi, Dr. Muya might be able to answer. Somebody is wondering why we have such few clinical psychologists. What's involved in training them? Why are they so few?
Dr. Moya, you want to answer?
You might not be the best people to answer, but we can try.
Yeah,
Yes,
okay.
yes.
Yeah, yeah. Let her answer. I'll chip in later.
There are few. I wouldn't say there are few, because now we have more universities training. I know Daystar is training, University of Nairobi is training, USU is training. Probably the limiting factor is, are they being absorbed into the public sector, or most of them are going into the private sector? But I don't think the numbers are as few as we perceive. Yeah. That's my input, I would think.
Yeah, you're right. I can't add anything else.
Maybe next time we will involve a psychologist to tell us a bit more about this. Okay, so there are no more questions. I believe we've had an excellent discussion. I believe that anybody who has been sitting in this discussion is feeling more comfortable now in being able to see children and how to treat them, where to refer, and all that. Is there anything else? No, I'm not seeing. Salome, your hand is up. Do you have a question, or you want to say something?
Not really a question.
Yes.
I wanted to make some input when it comes to the children who are referred to us. Most of the times after doing our assessment, we find that most children who have got delayed speech do not have language, not because they are supposed, they have a problem, but because the parents have exposed these children to the screen so much. And therefore you find overexposure to screen has led to many children having delayed speech. So I just want to highlight that overexposure to screen leads to delayed speech to some of the children. And then under stimulation of speech also leads to delayed speech. So to our parents, young parents who are in this forum, I would urge them that they reduce exposure of their children to screen, because overexposure has been found to lead to delayed speech, which is a big issue to most of our clients who come to us.
Very useful, very useful.
I'm sure Dr. Mondi has a lot to say about screen.
Oh, I tell you, these are battles. Yeah, thank you, Salome, for highlighting that. Even in our own hospital, those children who are admitted with other physical conditions, the cell phone is being used as a toy. And we actually don't know what those cell phones are doing to the children. But as Salome has said, they watch the screen. There are so many movements, there's noise. So they are interacting, the children are interacting with a dummy. So then, as she says, there is no speech stimulation. So we must put it clearly to the parents that children don't need those cell phones. And screen time should be reduced, maximum 30 minutes. The rest of the times playing or school stimulation, so that these children are stimulated in the right direction. Thank you.
Okay. Thank you, Salome and Dr. Mondi. Baron, your hand is up. You wanted to add on to this discussion about screens and stimulation?
Yes, please. Just to add on whatever Salome and Dr. Josephine talking about, basically children exposed to the screen, they tend to behave differently. And now with the sensory integration therapy, we offer stimulation, the right stimulation, or rather the right sensory diet to them. So as Dr. Josephine has mentioned about play therapy, when you come to our facility, you will find our setting is more of play therapy based, so that now we offer these children with maybe different sensory processing disorders with the right sensory diet. So if you notice that your child is presenting differently, maybe they are under responsive or even over responsive, then the reason why now you need an occupational therapist is now to offer the right sensory diet, just to stimulate them and now enable them to, to be able now to process the sensory input and now give out the positive output. And also now we have also occupational therapists in a school setup. So when now you refer them to an inclusive school, then now an occupational therapist over there will be able now to work with them even in the classroom in terms of concentration, in terms of even the writing skills and et cetera, et cetera. So when you hear about occupational therapy, you hear about the stimulation, you hear about play therapy, you hear about inclusivity, you hear about all these aspects that we are actually talking about and we are discussing. Yes. So I think that is what I wanted to say. Yes.
Thank you. I think we might need to have another forum discussion just to talk about what happens in occupational therapy and speech therapy in depth, and also maybe to also have a discussion with the education, somebody from KISE and somebody from the National Council for People Living with Disability, so that they just tell us what it is they do. Sometimes we refer there and we don't know what happens there. It's good for us to have a background knowledge of what exactly is going on. So we will in the future think about inviting them to just talk to us as well. So there are no other questions. 8:30 has reached. I know people have other things they might want to go do. I'd like to thank everybody who has been part of this. Maybe everybody will go around, just say something to close up, wind up for us. So start with Dr. Omondi.
Yes, first of all, I want to thank all my colleagues who have participated in this. I'm really, really happy. I'm so impressed. that they're able to give a feedback. We're able to share a forum like this. I wish it was physical, where we are able to discuss patients live amongst ourselves and make good, conclusive decisions and a good way forward. So I thank my colleagues. I also want to thank Sarah for steering this in a very, very good way. I mean, we've used such simple language, but I feel so empowered that, I would wish to have another one like tomorrow. But, I also want to say that some of these children do have chromosomal problems. And if their parents are able to afford genetic studying on their children and also themselves, then we also have pediatricians who are trained in genetics, and they are able to do the tests so that they know, should they want to have another child, then they can make an appropriate decision. But otherwise, thank you so much and blessed evening.
Right, thank you. Baron?
Well, mine is just to say thank you very much for this opportunity to just present and just discuss about matters concerning our children. And I just wanted to highlight that we have occupational therapy students from different institutions that basically joined, the ones from KMTC, that is from Nairobi, Machakos. And then we have students doing their bachelor's degree in occupational therapy, that they're in Puer and JQAT. And I believe if we have such forums, then we'll be able now to empower the young colleagues coming up and also trying to bridge up the gap. Yes, so thank you very much. And I hope one day we'll have like a physical meeting where now we'll be able to converse, which will be very, very good, Kabisa. Yes. Thank you very much.
Thank you, Baron. I like what you said. It's important for us to all like collaborate together, the different disciplines, because one of us can't work without the other. So it's good for us to know each other, know who does what, where to send. So asante sana.
Yes.
Yeah. Salome?
Yeah, thank you, Dr. Sala. I'm also very grateful for this forum, a lot of learning and a lot of insight. And to add to what I had just said before, we are also, the speech therapy is quite new in Kenyatta. They didn't start a long time ago. And we have quite a number of challenges. We don't have space. We have only 2 rooms and we are 3 speech therapists. And then we don't have not even anything to work. We have to buy our own tools to use for our clients. We've already started receiving students for their clinical internship from KU and also from KMTC. And therefore, I would really request or appeal to the institution if we can be able to be, given a better place so that we can be able to discharge our duties in a better way, at least a child-friendly environment, which we don't have as we are talking. But nevertheless, we are trying our best to render our services to our clients. Otherwise, I'm very, very grateful for this forum. I wish we should have it every month.
Yes.
We can organize something that's possible. Okay, Dr. Muya.
Yeah, thank you very much. It's been an honor, and the discussions have really been informative. I'm really grateful. I love child psychiatry. Yeah, so I enjoy seeing children, and I hope for everyone else a challenge. Sorry.
We'll send you the next plane for proper. Now that you're interested, I'll steal a bank.
Sure. Yes.
Oh, that's good. Yeah, we hope you'll be.
I'm hoping my yes.
Yeah. Okay.
Yes,
so,
I hope my colleagues will be able to. Yeah, it's okay. Yeah, I hope my colleagues will be able to start various child clinics so that the numbers are there. and not everyone can even afford to come to Kenyatta, and it's not even possible for Kenyatta to see everyone. So if everyone can start their small little clinics and help 1, 2, 3 people, that makes a difference. And and the light in the children's eyes, and when the mothers get answers and the fathers and the guardians, it's amazing. So I hope it's a challenge to everyone. And yeah, we should keep this discussion going. Wawa, you've been given a challenge for a physical meeting. We are in.
Okay. So we will work on it, but I think this is something we can do more regularly. Just meet, discuss, talk about things concerning the children, and see how best to go forward and how best to give them our services. So asante everyone and everybody who has participated. And so I will bid you all good evening and have a good night.
Good evening
Bye-bye.
too. Bye.
All right,
Bye-bye.
bye-bye.